Good afternoon, everyone. My name is Heather Miller, and I'm a healthcare, transactional, and regulatory lawyer in Nelson Mullins' Boca Raton office. I've been practicing law for over 20 years, with most of my career being with Mike Siegel. On the prior panel, you've already met Mike, and you met Jonah, but you have not met John Carter. He's a great addition to our panel here. John works at Pinnacle Consulting, and he helps various healthcare providers transition into the value-based care space, both perspective, but also because of his prior experience actually working with a provider. He has a unique set of experience that really is a benefit to his clients. So we're really excited to have John join us as well. And before we begin, I just want to thank you all for coming, whether you're online or in person. There are many of you that have supported this conference for almost a decade and come here every year, and I just want to say thank you for your support, and we really, truly love seeing you each year.
Heather, I want to mention, forgot, that although this is our third year, as Trish said, at a value-based care conference, we've been doing a healthcare conference since before we were in Nelson Mullins, for about 10 years.
Yes. So again, thank you all for being here, and thank you to our panelists, to Jason Helgerson and to the others who were on the prior panel and the next panel for being here, because we really could not have this conference without you. So thank you. And I also want to give you our first code of the day for CLE, and it's value. Shocker. So where do we begin? Some of you have likely had intense discussions during the last few months over politics. Maybe it was even about P. Diddy. But today, we have John and Jonah on the panel. And when the two of these guys get together, it is a lively, heated discussion. So I'm very excited for this panel. And what I want to say...
I heard most of it last night at dinner. They were sitting next to me, man, and it was nonstop.
Nonstop. And as Jonah says, he loves a great conversation. Anything nerdy is up his speed, so please feel free when we finish the panel to ask questions. You can also corner them when we're finished and ask your questions as well if you do not feel comfortable asking questions out loud. We have been talking about value-based care and ACOs for about a decade. When the ACO regulations first came out, Mike had us read thousands of pages. I think at that point it was somewhere between 700 or 1,200 pages in regulations. We were wondering why Mike was so excited about ACOs.
Yeah, it was a lot of reading.
It was a lot of reading. But Mike was the head of our practice. We knew he had a lot of experience in healthcare, and we knew his wisdom. So we all started learning about ACOs at that time. We started having conferences and discussions with clients, vendors, and anyone we knew to start preaching about changing healthcare delivery from a fee-for-service model toward a value-based care model. And what we have seen is that the early adopters of this methodology have been very successful. And what's important is not only have they been successful, but they've been successful purely just for cutting costs and improving processes. It's questionable whether or not quality has even been improved, I should say. So the reason this is important is because those early adopters are light years ahead of many others in this space. And so they will be the ones that will be able to take on risk and be more successful with that risk. Now, before I ask my esteemed panelists some questions, I would like everybody to stand up. Now, I might not have the best voice, but I would like everybody to sing the ABCs. And I will partake with you if you could deal with the fact that I don't have a good voice, okay? A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U, V, W, X, Y, and Z. Next time, won't you sing with me? So you're probably wondering why I've asked you to do that. You've been listening to 2 hours of straight lecture. I saw some yawns. I saw people zoning out. And also because this panel will be chock full of CMS alphabet soup. So now we can begin. So Mike Siegel, for those that live in the community and those who have worked with our firm for years, know that Mike is oftentimes referred to as the godfather of ACOs. And before we can really talk about the future of ACOs and value-based care, I think it's really important to hear from him as to the history of ACOs and where we are today. So Mike.
Well, Heather, you asked me about this, and I've been thinking about it. I don't know why I'm the godfather of anything, but the truth is that I got my start on ACOs through Kelly. I don't know where Kelly is over here. Yeah, I got a call from Kelly who said they were starting a big ACO. This was in 2011 that we worked on this, in which the government came out under the Affordable Care Act and said they were going to start these ACOs, which we never heard about. And they were basically, it was no downside risk, although truth is there's plenty of downside risk because you got to pay for everything that's happening, and if you don't get any money back, you're out the money. So there was plenty of downside risk. It just wasn't downside Medicare risk. And we had she had a group of physicians in Wellington, Florida, and near here, and that they were going to try to put together a big ACO. And I got involved with her, and it became one of the 27, I think, ACOs that were authorized to commence as of April 1, 2012. There was two types that it was April 1, and then you could also do it on July 1. I had a couple more that did July 1. April 1, you had to be really, really moving fast, and we did. And this was unique, I think, even later on, because we had specialists involved in this group, and they were not at the same level as PCPs. They were kind of second-class citizens, but nonetheless, they were involved, and they had an interest in the business. And it worked very, very well. And that group, which is the Palm Beach ACO, I can say, has been one of the most spectacularly successful ACOs in the country ever since it started. But at that time, it was really risky because you had to go from April 1, 2012 until December 31, 2013 was your first year. That was 21 months. And then you had to wait another 9 or 10 months before you knew you got any money. So this was like 2.5 years of risk. But Kelly ran it, of course, very, very well. And the doctors worked very hard at it. They had meetings all the time. And they had one particular doctor who was very, very powerful and good. And it was very, very successful. And there have been a lot of other ACOs, of course, over the years. Many of them have been extremely successful all over the country. And many of them have fallen by the wayside and were not successful. And then we can get in, there's not enough time to get into all that detail. But I can tell you that they gradually, of course, started to move towards downside risk. They offered the pioneer ACOs that had downside risk. And there have been many other types of businesses in their sense. And I don't think ACOs are going anywhere. And value-based care isn't going anywhere under this administration. They were married to it from 2016 to 2020. No reason they won't be married to it now. And besides which, it's too ingrained. They couldn't very well get rid of it. And they need to cut costs just like the Democrats. And so the truth is that there'll be some changes in strategy for sure, but the concept will be the same. And I don't know that you want me to say anything more.
That's helpful. And I think that I remember when we started working with that ACO and just ACOs across the country, a lot of the focus at the beginning was where can we cut costs? Where's the low-hanging fruit to cut costs? And at that time, there really was such low-hanging fruit. And then people started looking at the processes. But now we're beyond that, right? The margins on the cost cutting are thinning to a certain extent. Granted, you heard the prior panel talk about 80% of the spend on specialists, and that's where we can start looking next, where so much of the focus has been on primary care. And so I would like Jonah and John, whoever wants to take the lead, to talk about you know, where do you see ACOs and value-based care going in the next 10 years?
Yeah, sure. I'll take it first and then throw it to John. Where I see value-based care going is, I think, increased movement to downside. I think another really key point that Mike mentioned was that up till now, and COVID delayed this, there's really been a pretty slow movement to true downside risk, both upside and downside. There is inherent downside risk in operating an ACO, but we haven't had downside financial risk. And I would even argue that the initial benchmarks were high enough where realizing that downside risk was probably less likely anyway, and there was risk score buffering and all those things. So I think really what we'll see is a continuation of the current models to some extent, but with the increasing pressure of real downside risk and lowering benchmarks. The other thing that was mentioned earlier today, I do think we might start to see limited, but introduction of potential mandatory type models, possibly in limited geographies. If anyone remembers, way back when we did have when it was still called direct contracting, a direct contracting geographic model, which was released to much fanfare, and a lot of people were interested in it. It ended up getting canceled by CMMI for various reasons, but actuarially, I think that was somewhat, there are concerns there, but I think they could be mitigated. I think that is a model, if you're gonna go towards a goal of 100% coverage, that model solves a lot of actuarial problems for you. You get no selection bias, right? You don't have to worry about risk score growth, which is obviously something CMS is still very, very concerned about. We'll continue to be concerned about paying revenue for growth in risk scores that they feel is not due to true patient acuity increasing, but due to better capture of those codes. But in a model that's closed, like say in Atlanta Metro, where all lives are now going to be distributed, so we're covering immediately, day one, where you have 100% at risk within this area. Risk scoring will be recognized, but we will say Atlanta's risk score will not go up. So while the individual entities can do a better job coding their individual patients to get credit for them, there is no overall revenue risk to CMS or CMMI of increased risk scores. And it also promotes specialist engagement, because we're now guaranteeing that we're getting a market basket, a true market basket of patients that are going to have various conditions that need to be treated. So in my mind, I think it's going to be a continuation of the current total cost of care models, refinement of them, probably some introduction of additional carve-out models, but I think most of the growth is really going to still be around primary care, attributed lives, getting towards 100%, and possibly finding ways to either mandatory or voluntarily bid on total lives in an area, and possibly growth in that way, which we can get into later. That'll change some of the incentives in the program and some of the ways that you would manage that cost. I'll throw it to John though before we go any further.
I agree wholeheartedly. I think in short, what I would say is we've had a decade where we've rewarded process, and I think the next decade is going to reward outcome. And what I mean by that is we've identified our patients, we've stratified our risk, right, the HCCs of the world. We've started the processes of closing gaps in care, the diagnostic testings, to make sure that people are actually involved in their health care and doing the things that we need to do from a process standpoint to drive the model forward. But now we're moving to an era of inevitably no outcomes, no incomes. And I don't think that from the fee-for-service chassis that we're going to fully break away. There's too much entrenchment in there. An RVU is an RVU, right? A DRG is a DRG, the way the system is paid. I will say that you will see it probably more on the outpatient side. A lot of what Jonah was saying is a word that we don't typically say out loud, but it's capitation, right? We are trying to move more and more towards a capitated model. I think that the future of value-based care not only focuses on what are you doing with your population in terms of outcomes and improving from a preventative perspective. As Trish mentioned, the Commonwealth report continues to show that we are amazing at acute episodic care. We are terrible at disease states and chronic management. And so how do we turn that tide? How do we focus on outcomes, and how do we do better? But I also think from a system perspective, the reason we have to go there and the reason we have to get there quickly As Jason said, I actually had a conversation with Liz Fowler at a conference earlier this year, and she said, we knew this was going to be a marathon. We didn't realize it was an ultra marathon. And I agree, we should be further than we are, but I think it's because we're putting the foundation in place. The CBO report came out. They said you've tested, 49 models. You spent $5 billion. Where's it going? What's it happening? But, Jonah and I last night, we talked about you have to throw these things against the wall to figure out what's working and then take the best of those processes and start to hone in on what the future is going to look like. So they did inadvertently create the war of attribution, but by and large, they're trying to figure out what's actually going to move all of these different levers. And from a system perspective, we don't have enough physicians. We have a physician shortage. We know we have a physician shortage. We have more water going out of the bathtub than we have coming in. More physicians retire every year than we can produce. So how do we optimize the business? And for the hospitals and health systems right in the room, you probably think to yourself, we have to have heads in beds, right? But the idea that value is created by scarcity, especially in healthcare, just doesn't make sense to me. Healthcare demand is inelastic. The demand is always going to be there. In fact, our specialists are bogged down, right? It should not take that long to get in to see a specialist, but when you have specialists doing primary care activities, like your cardiologist seeing that patient because they have CHF and they don't go to their internist, right? If you have an endocrinologist that's taking care of their diabetes population, but they're not getting an annual well visit with their internist, like those are problems. And so from an optimization perspective, the next evolution is going to be, how do you take care of your population and improve the total outcomes for that population, which I think creates capacity from an already resource-constrained environment and a capacity-constrained environment on the system side. So you'll actually do better in fee-for-service because you've maximized throughput. You've actually optimized the system while still making a high margin, high EBITDA return on your ability to take care of the people within your catchment. So I actually agree wholeheartedly on the market basket, kind of moving back to geography, because it forces you to inevitably steer away from cherry picking and limit dropping.
More on that, I was talking to one of our attendees, and she was saying that specialists around the country, they're buried. They got so much to do, and they don't have time. So the old idea that we used to have, and that we would give them they'd give us a discount for the volume. They don't need the volume. They don't want the volume, and they're not going to give you any discounts. And you've got to come up with a different method to be able to make this work. And basically, you've got to be able to streamline it so that you take into account the fact that we have fewer specialists all the time, every year.
Yeah, and it's the smallest portion, right? I mean, we have 90,000 internists, we have roughly 90,000 family medicine physicians. There's still a dearth of primary care, but when you look at the specialty market, it is extremely small. When there's roughly 18,000 orthopedic physicians in the country, that's just not enough as our patient base lives longer and healthier lives. If you look at GI, if you look at urology, pulmonology is the oldest practicing specialty in medicine. The majority of those physicians are retiring. And the problem is that COPD is still roughly the third leading cause of death in the U.S. and the only one where the death rate continues to rise. So I go back to a capacity-constrained environment. How do we create a way to optimize both sides? And so I would say the next evolution of that future is the payers have been in the risk game for a very, very long time. We're new at it. Right? They know how to really look at their markets and to figure out where that spend's going to be and in turn make a profit. That's why they can budget a year in advance. I also think the next evolution is really going to be a focus on a tipping point of how do we address benchmark ratchet. Right? We can't punish success, so you can't keep moving the mark because I did so well that you raised the bar and now I have to compete against myself and punish myself for success I previously had. So there's got to be, to your point, some kind of reckoning there in the center.
Yeah, absolutely. I agree with everything that was said there. Another concept that just kind of came to my mind as we were talking, that I don't think I said explicit, we spoke about it in the last panel. The last panel was sort of all about this. I do think the movement over the last 10 years has actually been maybe to kick specialists out of ACOs because of adverse risk selection and sort of not getting complexity in getting a fair benchmark for those patients. I think over the next 10 years, it'll actually be reintegration, but hopefully proper integration of specialists in there. A couple of our questions have been, I think PCPs are somewhat all alone just attributing this risk and finding ways to do something with it. So accumulation of lives, that'll probably continue, accumulation of lives. But I think skin in the game for providers, for various phases of care, I think will grow. We're only now just seeing it with many of the ACOs we work with, that they're gain sharing in an intelligent way with their underlying participants. Many ACOs have been simply distributing savings, per life. And that's really not what the best way to do it, or the best way to communicate to your participants their performance, right? So even amongst the primary care participants, many of them have not been individually at risk for their own performance within the ACO. That's starting to change, and I expect sort of the next evolution of that will be skin in the game for those that are impacting care but aren't attributed lives. And I think that will be the differentiator that allows ACOs to continue to succeed in a world where there will be some ratcheting, unavoidably, hopefully not too much, but the way they'll continue to succeed is by engaging other specialists.
I think, we sit here and we talk about these theories and these concepts. I do find that for people that are attending, it can be helpful for them to hear specific examples. So you talk about gain sharing with specialists. Can you maybe give specific examples, obviously not use names, examples of the types of gain sharing that are taking place, and then maybe we can parlay that into a discussion as to whether or not we think CMS will start coming out with more models to target specialists and what those might look like. Are you
Yeah.
able to have any examples that you can share?
Yeah, certainly. I can share a couple. So what we've started to see amongst, in the commercial space as well as the Medicare space, are bundles built around certain episodes of care. So specific episode of care bundles, we call them shadow bundles, and I think that's an appropriate term. So bundles that live, not necessarily are carved out from total cost of care risk, but live underneath the total cost of care risk. And I continue to think that shadow bundles will play a large role. And it's interesting, so CMS, just to speak to this, CMS recently started making shadow bundle data available for CJR bundles within ACOs. Nothing much, there's not much exciting about it. They're literally just telling you, hey, here's a bundle that's underneath your ACO, and here's the data. But they're organizing that data for you, for the ACO. It doesn't really affect the ACO anything, but it is information that they're now being made available that they can more easily track and manage. I would think that a way that CMS might introduce shadow bundles into these broader arrangements, they continue to try to grow total cost of care risk through MSSP, through whatever succeeds REACH. Continue to grow that and possibly do some of the analytic work for the ACO in developing and piloting individual bundles beneath the ACO that are informational, but in reality can then be used by the ACO to go out and engage certain specialists to manage cost of care. So I mean, certain bundles, we've certainly seen bundles on the post-acute side. So ACOs are operating their own post-acute management of care underneath the ACO. So I'm working with my hospitalists, I'm working with my specialists to make sure that efficient sites of care are utilized after an acute admission. And that's all just coming from the ACO itself. We see oncology bundles. Certainly we've seen CMS. We've seen nephrology bundles indicated in, and again, what goes into that is often painful, although in the longer term it's not painful. Painful initially. Let's define what should be in this bundle. Risk adjustment is a huge issue, so how do we properly risk adjust? We like to say always that risk adjustment is not just a risk score, it's also what's included in the cost and not, right? So risk adjustment doesn't have to be a score that perfectly predicts the level of acuity of your patient. We can also do things like remove costs that are highly variable or that we don't want you to be at risk for, right? Defining what's at risk and what's not. So what we've seen in a lot of these bundles is a lot of painstaking work goes into let's define what's in and out, what we want you to be at risk for, what are the key performance indicators that we need, our heart surgeons to be at risk for, our nephrologists. How do we define success for you? And then we'll give you a share of your performance on that bundle. And so we'll measure it over time. And oftentimes these shadow bundles can be upside only. we touched on this maybe at the end of the last panel. I thought it was interesting. I think downside risk proliferating for the PCPs and for the broader entities that are taking risk motivates a lot of this. I'm not sure that you necessarily even need to have robust downside risk initially for these specialist bundles. You just need the incentive to exist to manage this better, and offset potentially different revenue that's gonna come through, right? So the incentive is there for you to do something different and manage things. Oftentimes when we speak with specialists within an ACO, they already know a lot of things they could be doing to do better, but there's just no incentive or no organization for them to actually do it. There's no connection with the PCP to actually organize some of the things they want to be able to do. So I think those are a couple of examples, but I think the primary example I'm thinking of that may grow is shadow bundles. So defining smaller episodes of care, bite-sized episodes of care that can be well-defined, well-risk adjusted underneath a broader total cost of care umbrella, and then proliferating those. And I think what goes along with that is then benchmarking and choosing truly high-performing specialists to then be the primary participants in the ACO in managing those episodes of care. I'll throw it.
Yeah, absolutely. From an example perspective, I will say two things. One, just because we've kind of talked about this a little bit, but I think that sometimes value-based care gets a bad rap as a race to the bottom, right? And it's not a race to the bottom. It's not all about cutting costs. It's about doing better. That said, I will tell you from examples, lessons learned along the way. So, Heather mentioned my background. I worked at an IPA, CIN, had about 650 docs across 250 practices, neurosurgery to pediatrics. We were heavily in the ACO space, not only on the commercial side, but also on the Medicare side. And so what we found early on is as we kind of moved through the staircase, which if you guys have the slide deck, the slide is in there, but as we moved through the staircase from fee-for-service to quality incentives to pay-for-performance to shared saving to bundled payments, et cetera, we realized quickly that from a cost control perspective that we didn't understand how to manage the cost in specialty care. And I would say most ACOs will probably tell you the same thing. Like, we've tried this, it's hard, we haven't figured it out. Now we have more data, and I think we're gonna make more informed decisions. One of the things that worked well for us was going to the payers and creating pay-for-performance contracts. I've got to find a way to engage my specialist. I know that I've got this ACO that's PCP driven. Give me something that helps you reduce your total market cap spend, because I know that's what your focus is, going back to Jason's point on how you negotiate with payers. But then secondarily, that drives performance. So we were able to get metrics like, right side of service. In other words, stop using the hospital, stop using the HOPD, drive it to a freestanding surgery center, which is great because all my orthos have JVs in the surgery center anyway. They were happy. Low cost, high quality imaging, and then generic utilization, building stop gaps, looking at step therapies, et cetera. But how do we drive that performance to drive down costs, and then sharing that back with our specialists? And it worked. Then we got into quality, then we got into bundled payments. The payers didn't want to play that game anymore. You've got to figure this out with your specialists. We don't have the data. And so I think that's another place where there's going to be opportunity. And so in terms of innovative models, you're right. There are headwinds that we face in this space, but we have to get there because we're approaching 20% of GDP. So we've got to figure out the cost component. There's a lot that we can do in the cost space while still providing better outcomes. But I think if you look at some of the things that you can do, even, and this isn't about VBEs, but some of the interesting things that we're seeing in VBEs are that people are finding ways to get creative and cutting the payers out altogether just to optimize their own business. So if I can work with my orthos and optimize my service line on preference packs, right, and I can help share in some of those rewards. If I can build a steering committee or a guiding coalition to reduce the average length of stay, if I can work on discharge planning, right, if I can get my surgeons to have a first case on-time start, right? Like little things like that, and then figuring out how to protect and reward that remuneration. And you're right, you don't have to start big. You don't have to go to full downside risk. You don't even have to go to the moderate risk. Care coordination is a great example. That's more of an upside where you can actually pay for those different things. The OIG's example in that VBE was paying a physician every time they referred for a dual modality cancer screening instead of a single modality, which, all the lawyers in the room, their spidey senses are going off, but that's the example that they used. And so I think what we're finding is innovative ways to optimize the system, and I do think that we've got to find a way to move everybody back, because what happened is we couldn't control specialty costs. I'm a great example of that. in terms of what we were doing in our ACO. So that's when you saw the EOM model come out, and they're going to start taking capitated risk for oncology patients. That's when you started to see what's happening in CKCC. That's what you started to see, and what potentially could happen in GUIDE. Like, we don't know, but our neurologist going to start getting PM dollars for the GUIDE model in dementia? Like, we don't know what that's going to look like. So those are PM dollars that are being carved away, in essence, from your ACO, from your PCP. So how do we get everybody working together and then create innovative models and use these mechanisms that we've been given to really find a way to just do better? We know how to do better. We've just got to start incentivizing these behaviors until they become ubiquitous.
So in addition to changing the incentives, do you see a shift from, being able to select your population to these new models essentially dictating who you have to care for, right? Because if you're able to cherry pick, you can't really get at the true population health and total cost of care for the population that costs us the most money.
Yeah, I'm going to let Jonah talk a little bit about that, and I want to hear from a legal perspective, but I will tell you that's a quick way to get in a lot of trouble. Cherry picking, lemon dropping. So yes, I think there is going to be opportunity, and yes, I do think, to Jonah's point, as you look at a geographic market basket, it kind of eliminates your ability to do that. So I don't know what you're seeing just from a data perspective or what you're seeing in some of these
When I hear
arrangements.
cherry picking, I get nervous.
I got nervous when she said it.
Yeah, we don't use that term.
You didn't hear it.
No, but
But carefully selecting your patient population.
Exactly. Yes. We certainly see patient selection. This has been it's been a topic of conversation since the beginning of time with that Medicare Advantage, that concerns about natural selection. And I do want to get past, we joke about it. I don't think there is an abundance of actual cherry picking going on. I think what's happening is there are risks within the market that are that are priced better. HCC model is not a perfect model. It doesn't reach every cohort of the population equally. So actually, I think we will see more dictated populations. And one of the advantages, I think, like an actuary, when we're designing a study, one of the things we want first is we just want a representative sample. If we get a representative sample, we can do all kinds of interesting things with data, and a lot of our problems go away. Risk adjustment doesn't matter so much as long as you have a sufficiently sized a representative sample. But if you have a sample that's heavily skewed away from certain specialists, well, now maybe risk adjustment might be overpaying me for these patients. That's a question. If I have a patient panel that, let's say I'm a home care provider and I'm trying to take part in the ACO model and I'm attributing these lives, they're getting a decent risk score, or I'm an oncologist. We've seen this in the ACO models. The patients that naturally attribute to me, if I'm an oncologist as part of an ACO, aren't really fairly priced via their risk score. And I don't think anyone from CMS would think they were either. So when we have a bifurcated attribution model, we have problems that we don't have once everybody's joined together. Now, if you're getting a market basket risk, your risk score is probably indicative of your population risk score, and you can rest easy that you're not getting an unfair benchmark. I think in the current environment, there is a valid concern from those participating in the ACOs that if they're not careful about selection, who's in the ACO, who's not, they might be getting a very unfair benchmark for their population, a benchmark that doesn't enable them to perform even if they do all the things they're supposed to do. And so I think CMMI is aware of this and really interested in finding ways to make this less of a problem. And sort of the upside, a corollary of this problem existing is that yes, you can end up with a better than market basket risk of patient risk that allows you maybe to perform better than you would otherwise with a market basket risk. But you can also end up with a poor market basket risk. A good example of how CMS sort of addressed and acknowledged this reality was in the MSSP rule when they took away the negative regional adjustment. The reason they took away the negative regional adjustment, and I'm way in the weeds here, but it's basically if the regional rate, if you take part in an ACO, you get part of your rate is based on your own historical expenditures. Part of your rate is based on a regional rate similar to MA that's risk adjusted. And what they were finding was there were enough specialist ACOs that were just getting hammered by the regional rate. And when you looked at it, it wasn't because they were inefficient or they had a wildly out of line benchmark. It was just that their corner of the population that they're pulling from wasn't adequately described at their scale by HCC, and that wasn't easily solvable. So the solution was, well, we really wanted, the reason that exists is on the positive side to help mitigate the race to the bottom. We want to pay for people who have already achieved these things. If you're a Kaiser and you've already done a ton of really good work, we want you to still participate in these models and be able to succeed, even though you're already efficient. But what they did is they took away the negative. And I bring that up only to point out that this has been, that's an acknowledgement that there is problematic risk within the population that isn't priced perfectly by current models. So I think what's going to happen over the next 10 years is an attempt to either carve that risk out. We have a concurrent risk adjustment model, a new HCC model that was introduced as part of the high needs model, finding ways to leverage that to better pay for complex risk. But finding a way, I think the general theme would be get more complex risk under management. That's really where the dollars are that we need to be managing, and find a way to do it fairly. And so I think that's really the takeaway I have, is that we have this problem of the highest concentration, highest comorbid risk is actually difficult to get into current models and get paid fairly for, get benchmarked fairly for. I think that over the next 10 years, we're gonna either through market basket risk, which naturally solves this, or through more use of a concurrent risk model or other risk mitigation techniques or other episode models. CMMI, I think, will be very motivated to, as they're approaching that 100%, really target that 20% that's the highest cost that we really want under risk, maybe even more so than the other populations.
Do you think that's driving some of the excitement in the DSNP or the concurrent?
Yes, I think the concurrent risk model is a pretty meaningful, it's gotten almost no fanfare.
Right.
But I think it's a it's a fully developed new risk model that's on a concurrent basis, which people have been asking for a while. Meaningfully, in one of my earlier graphs from the last session, it's actually in there. We didn't highlight it, but it has a different relationship to cost on the cost curve, quite materially, in that it scales up much more in the higher. It's obviously neutral relative to the current risk model, but it pays much more higher up here in the risk model or in the cost curve, and less down in the lower cost patients. So I think it's pretty interesting. I think high needs in general is a space we're seeing immense amounts of growth and attention. CMI is probably going to keep pushing on that model to make it work just the way they want it to work, but I think a lot of really interesting returns in that model so far.
I got to tell you, it's really it's great to be on a panel with these guys. You don't have to say anything.
I was going to ask if you were seeing innovative game show or new models that you're creating.
You know, I remember back in 2009, I gave a talk and I had a PowerPoint. I found it. I was looking at it a couple of weeks ago. It was called "Times They Are Changing," and I had Bob Dylan quoted all over the place. But that was 2009, and from 2009 to 2024, we've had a lot of change. But if you can see, it's only been a bit. It's only been a piece.
Mm-hmm. Yeah. Well, and a lot of that thing too is, and not to get down the healthcare policy train, but I think healthcare is a kludrocracy, right? It's a very complex, very complex adaptive system that we have inevitably applied Band-Aid fixes to over the years. And so while we're making change, we're making incremental change, but we're all moving in this direction. So there's going to be some wins, there's going to be some losses. So, you know, again, I wish and would have hoped and thought that we would be a lot further along than we are. I don't necessarily think that we're at the tipping point, but I do think that that growth curve is accelerating. And I also think from a system perspective, the folks that have kind of not gotten their feet into the value-based care world are really looking at it, because, you know, healthcare is one of those unique environments where we're not allowed to pass the cost of inflation downstream because our rates continue to go down. We just took another 2.9% cut in the latest rate. And so, you know, if I'm a system and I work in margin compression and my role is to maximize every dollar, if I'm not working in value-based care, I'm not maximizing every dollar. I mean, the report just came out. We say $5.2 billion, 3.1 of which went back to providers. That's a lot of money that was left on the table for people that should have been operating in this space. And what piece of that pie would they have been able to take and really help perform for their system?
You know, one of the things we see from a legal perspective is there, of course, are primary care doctors who produce very, very well, and there's some that don't. And yet that data is available. And there's a constant fight between ACOs every year in contracting with the people who do really well, and they're willing to give them a little bit extra and all this stuff. And they often have contracts. The ACOs will enter into contracts with these people for 3, 4, 5 years till the end of the program, and yet the other guys are still trying to steal them, and we get into litigation over that. And but that's you have to set up they try to set up the practice, because if you start out with a bunch of guys who don't know what they're doing, you're not going to do very well.
You actually bring up a really good point that was on a slide earlier. With the election going the way it did, if private equity is welcomed into the space or allowed to continue into the space, we will likely see as these programs grow, there will be competition for these lives that are attributed to primary care docs, and not even their current lives. There's ways to change primary care practices to attribute even more, right? With nurse practitioners and other less than doctor participants. So I think I think there will also be a race. I think the terms that we're still talking about in value-based care are still generally favorable to participation. Less favorable than maybe initially, but still pretty favorable terms, still very manageable risk. And it's a lot of dollars if you can get your hands around effective ways to manage it. And so I think the data exists to profile physicians in Medicare, who's performing well, who's got the best risk to cost ratio. That data is out there, people are leveraging it. And I think there will be competition to maintain participants in ACOs. And some of that competition will come down to gain sharing, risk mitigation, what are you offering? So I do think there will be a lot of innovation and gain sharing, both from the primary care side and possibly a specialist side.
So what I'm hearing really is that taking on complex risk, engaging specialists, and being open as primary care physicians to push down some of the financial benefits to specialists so they could really bend the cost curve. So, but with that said, what are the other, I guess, obstacles that you all see with respect to what VBC is likely to face moving forward? There have been so many changes in the last year, and that's going to impact the ability of whether you're a value-based enterprise, an ACO, or involved in some other Medicare program. All these changes impact the ability of someone to be financially successful, and even more so, to be able to prove quality, right? So as we move away from reducing costs and focusing on process, you now have to merge all this together to show quality. So what do you guys see as or do you see other obstacles to achieving that goal? Obviously, technology is one, and your data analytics, but what else?
I'll let you go first.
Yeah, I mean, again, I think there's a number of headwinds. We look at what's happening just in the HCC space with the version 24 to version 28. I think there's going to be some wins and losses. I think on the one hand, it's going to be a little bit more complex. I think on the other hand, it allows for more specificity. So you are going to see some of that turn down, but I also think that, this unspecified diagnosis isn't going to carry the same weight. So you're going to have to be a little bit more specific in how you approach that. I also think we talked about specialty models. We talked about PNPM carve-out that's coming into these models away from PCPs. I think the CMMI refresh and focus on specialty care. They're sharing data. They have a focus on specialists. They obviously realize that's where a lot of the spend is. We'll reach sunset. What's going to replace it? What's going to happen to the MSSP bonus, right? All of these things I think are in play. I will say, regardless of how the election turned out, we're going to continue to move down this path because we have no other means. The idea that we're going to repeal and replace, I just don't think is fathomable at this point. We've been through 3 administrations. We've already put the infrastructure in place. We've already gone down the EMR route, the EHR route. We've already started doing all of these different things. And frankly, I think if we tried to just uproot the whole thing, there were 2 quintessential roadblocks that I think drove the ACA. Number one was when we repealed SGR, even though the new Medicare physician fee schedule cuts over the last 5 years are very indicative of the continuing resolution that we had in the SGR space. But we repealed SGR, we put in MACRA. King versus Burwell said that subsidies were here to stay, so you're gonna have a marketplace. Now, it may look different, but those are the things, plus the infrastructure that got us to where we are today. We know that we have to address the total cost. And so I think you're going to see more movements towards capitation. I think that it's how we operate in those spaces, and I think how we get the other parties involved that are going to make the difference. The biggest obstacle that we face right now is that we are tied to the fee-for-service chassis that frankly is going to be extremely entrenched and hard to uproot, because that's how everybody has done this for so long. That's how payment mechanisms are made. That's how bonuses are paid. That's how all those things I mentioned earlier from a work RVU or from a DRG perspective are locked in. And so if we're not going to get away from fee-for-service, then what are we comparing to? So the next evolution of challenge is, well, what are you benchmarking to, right? What are you comparing to? Are you comparing to my cost savings over fee-for-service, other ACOs, other models? And so there's going to continue to be innovation, but I think the benefit of the last 10 years is it gave us a really good foundation and a really good base to start implementing the best practices from all of those models and maybe figure out what's going to work forward, but we've got to get there.
So with that said, right, we're talking about primary care, we're talking about specialists. When you're part of, I don't want to say smaller organizations, but when you're part of your own organization, you have greater flexibility to make timely decisions, right, and adapt and make changes to address what comes out on a daily or monthly or annual basis. The question, right, it's always the elephant in the room. What about hospitals, right? What do they do with all these changes in a way that will allow them to remain financially sustainable? I don't know if there's an answer. I don't know if anybody has the answer, but,
I got some thoughts, but
I'll just say, I'll reiterate, and then I'll let you say something controversial maybe. I think the main headwind I see in this whole program is really, it is that fee-for-service chassis. Just that is how we have paid for healthcare. That's how everything's built. This is a reimagination of how you generate similar, maybe less revenue overall, but like the redistribution of healthcare revenue that results from transformation to care is just a barrier. And I would say it was on the slides earlier. There is a motivation gap here, right? Like not every single person who is participating in healthcare right now is anxious to move as fast as we can down value-based care pathway. I agree with John. I don't really see that there's another option other than just sticking with fee-for-service and letting that run, which I think is sort of financially inviable at this point. And so I don't see, I agree, anyone who comes in, I think is going to try to continue to iterate on what we have. And I think what we have in value-based care is actually pretty good. There's good bones to it. The things that are potentially holding it back, I don't think are the structures that we have in place or the thoughts that we put into how to share. It's really, is it going to be mandatory? Are we going to force this down? Are we going to enable people to look at this with a multi-year view, a multi-year long-term view? Year-to-year volatility is an issue in terms of financials, predicting how you're going to perform and having to have that money on hand and ready to distribute if you have losses. These are all business challenges that are not insubstantial that exist in the space. I think many of them get solved by more adoption, heavier adoption, and a multi-year view. We could, and so I think that's kind of the main piece. But yeah, there's a difficulty here, which is fee-for-service at the moment, had it continue forward, would probably be more profitable for almost all participants in the space than whatever is going to happen with value-based care. And it's thinking about how we transition from where we're at, because it's unsustainable, to the new future that is sustainable and does allow excellence and revenue gains that are within a sustainable model. So I think that's the main headwind. It's a transformation of how we pay for healthcare, and it's not always going to be easy or the best short-term outcome.
And I think as Mike was saying at the beginning, with the times are changing, They are, and even if you are not looking to move from fee-for-service tomorrow, those that have walked will be able to run, as, right, you said in the opening. If you do not start laying the foundation now, you will be so far behind the curve when you are forced to make that change. So even if you take baby steps, but just do something. Questions, Lanny?
Yes. Is there an issue structurally with the fact that payers have no incentive to reduce the overall cost because how they get paid versus Medicare has a fixed budget and there's somebody looking over top of them and they're trying to find their best way? And you got the providers who are schizophrenic. Do I do this way or do I do that way? Does it matter what patient's in front of me?
So we can talk offline. I am happy to talk all things medical loss ratio and why people are incentivized for the overall pie to get bigger because their slice gets bigger, which I think is a conundrum. What I will leave you with is two things. One, I think that working in value-based care in the commercial space was a lot harder than it was in Medicare because Medicare is very predictable. You got some heavy lift, you got some maintenance phase, right? You can do well. In the private sector, the goalpost shifts every year because they're only focused on where their cost is. Well, Aetna's cost this year is out of control in this area, but United's is in this area and Blue's is in this area. And so from a contract negotiation perspective, it's how do we right-size all of our value-based care contracts to focus on the consistency and how we address our total population, not how I treat my Aetna population versus my Blue population, et cetera. For the question about hospitals, the last thing I would say is you have to control the narrative. Right? We are hospitals, we are here, this is how this has always been. There's not going to be disruption. And then what happened? Everybody went after your profit centers. They went after your profit centers and realized that we could rent rooms from the hospital instead of having to put capital intensive money into the brick and mortar. And so just like you did a really good job when you acquired these physician groups and building brands around your entity and your name and creating that loyalty, you have to do the same thing in value-based care. You have to take care of those patients that have aligned to that loyalty. And if you don't control the narrative, there will be more disruption and people will figure out how to take those patients away from you. And to the point that was made earlier, then you will be downstream.
Yeah.
And you don't want to be downstream. So we've got to get people moving in this space. But the last part of the payers, we can talk offline.
And then also, right, we have the TEAMS model. So that's just an indication of what things are likely to start looking like for hospitals down the road. But I think we have about 5 minutes left, so it's a great time if anybody has any questions. Sure.
We keep talking about cost, but we've also alluded to the fact that quality has to change. Who's going to define it and how are they going to define it? Because I go back to basically a restatement of an old proverb, you know, beauty's in the eye of the beholder, quality is in the eye of the beholder. And I think that's an extremely important factor that we have to start thinking through. And I'd like to hear your thoughts about it.
Yeah, I'll share some thoughts initially. I think where we're at in terms of quality measurement is way earlier in the phase than where we're at, even with outcomes measurement. And we're not all the way there on outcomes measurement either. I do think thinking of quality in terms more of outcomes is increasingly the way that it's going. The challenge there is measuring that appropriately. But I think that it tends to be where I'm seeing quality measurement go and maybe somewhat away from the survey data that has been the norm. And I think me and John were talking about this, there can exist perverse incentives that arise from quality that conflict with outcomes measurement. And I think ultimately what will drive this is we want the best outcomes for patients and the best access and all of those things. And I don't think that quality will continue in a way that is sort of separate and apart from that. I think we're working towards ways, and CMMI is introducing more and more measures that are claims-based or outcomes-based that can be measured. And I think that's ultimately where we go with quality. I'll let others speak on it as well.
Ditto.
Yeah, I agree with you. Quality is in the eyes of the beholder, and all these little quality measures they come up with, patient satisfaction, how does the patient know necessarily? They know something, but not everything. And,
Patient satisfaction, increase in defensive medicine.
All right, we'll
but
take another
I
question.
don't know the way to solve it. I mean,
Guys, what's the patient's responsibility here? Because you have two segments here, two different thoughts here. First one is CMS, I want to pay less. 20% GDP, I want to get to 15% GDP. I can do that through a bunch of different ways, offloading to medical advantage. I can actually pay the doctors less. Then you have commercials that are also involved in that too. What about the patient's responsibility about taking care of themselves? If you look overseas at a lot of these other models, they're incredibly proactive. HMOs didn't work here. And part of the way of getting this number down at some point, because even in the perfect world, there are going to be disgruntled people on both sides of the equation, and somebody's going to take a fall or somebody's going to get paid less, or there will just be less in the system, even at the best possible advantage in terms of all of this working. How do you actually get the patients involved to kind of ratchet it down even further? Because there'll be less cases, earlier interactions, things of that nature.
Absolutely, no, and that's a phenomenal question. And there's three legs to the stool, right? There is the provider, there's the payer, and there's the patient. And there's not been an onerous amount of responsibility on the patient. I mean, we have employer-sponsored plans that have wellness, and we can reduce your deductible, and we're doing all the right things. I will tell you this: value-based care is like the old adage that we are planting a seed for a tree whose shade we will never sit. We are trying to turn the tide generations from now because we have to catch up to the other economically developed countries. Where I think HMOs failed the first time around is that they didn't take into account how to take care of the patient. It was all about cost control. So again, race to the bottom. This time, I think if you look at the work that's happening in FQHCs and the fact that they're actually able to engage and to really make positive change with that population, which is frankly where they're located, is ideal. I think what we did not do a good job of is we, compared to those other countries, did not continue to develop or to invest in our social infrastructure the way that they did. And so I think for the short term, it's, again, I was in the Army 14 years, right? They don't care how much you know till they know how much you care. And so you really have to engage with those patients. But the challenge from the regulatory perspective is patient satisfaction going up is also a byproduct of defensive medicine for these physicians, because I don't want to be told that I need to work out and stop smoking and stop eating fast food 4 times a day, and I want the pill, right? And so some of that goes back to the whole kludgocracy of the system, which is how do we get away from a lot of the things that are happening? We've tightened down the reins on Medicare Advantage and how they can market, right? But what about pharma? We're the only country where they can market direct to consumer. So we're not going to solve that problem today, but I think what we can do is make positive change by taking care of the patients. As I used to say in the Army, you have to lead the people who have entrusted you to do so. If I trust you to be my physician, then I need you to help me take care of it. You're never going to solve it for everybody, but you've got to make as much progress as you can with the ones that you can really get the buy-in. And I think by having them do the right things, and we've rewarded those processes, they're starting to be more acutely aware of what they need to do and how they should interact with the system. There is no patient education from the system. And again, somewhat by design, because the pie gets bigger, so does my slice. So we're not going to solve that problem, but I agree. So how do you put that responsibility on the patient? We're using the best levers that we have through the employer-sponsored plans, through caring for the patients, through trying to get them to be vested in their own personal health care. But there's always going to be that cohort that says, this is America and I do what I want and just give me the pill, and you know what I mean? So
I think it's generationally driven too, right? As you go down the road, you're going to get more people who are, I guess, more in health and everything else that benefits their own bodies. You've got all these baby boomers that are coming up. You said they're not that far away from being going to the next generation. And these are people who may or may not be taking care of themselves, who have advanced diseases, and the numbers just keep spiraling up.
Yeah.
And CNS doesn't want to go that direction.
Well, that's why they struck a deal with the private insurance to offload 50% of the market. And so what do? You try to ratchet them down, and then they go, fine, you take them back. We can't afford to take them back. Well, you keep them, we'll figure it out. So that's the world that we live in. There's, that's the ship that's kind of already sailed. We got to do the best of what we can. But you're right, we have to make generational differences. I mean, we know that the #1 prescription for malnutrition is good quality, nutritious food. So how do we address food deserts? So going back to social determinants of health, I think that is going to be a big key. I do think that health equity, if 5% of the patients are worth 50% of the cost, if we could just make a difference in the poverty and the chronic disease and the end-of-life care, what could we do with those savings? So there's ample opportunity. We know what to do. We've just got to execute. It's all execution at this point.
So
I don't know if that
John,
answers your question, but.
John, Jonah, Mike, I want to thank you for participating in the panel, and you know where to find them when this is over if you have any additional questions. Thank you.